Hello, and welcome to today's Benton House Bites, short Alzheimer's and memory care orientation videos designed to teach caregivers how to help relieve common behavioral symptoms associated with memory loss. These videos are the very ones we use to improve the skills of our own team, and we are proud to share them with family caregivers as well. I'm Brandy Atchison, aka Brandy Bettenhouse, and I've been with the Bettenhouse family since 2017 and am a nationally certified Alzheimer's and dementia care trainer. Remember, most memory loss behaviors or challenges are symptoms, not intentional acts. And just like if it were a physical symptom, our job as caregivers is to relieve pain and provide loving support. Your response can make a meaningful difference and provide real comfort to the senior in your care. And with practice, you will become more skilled and more comfortable in your caregiving, benefiting both you and your loved one. Joining me today is Dr. Figiel. Dr. Figiel is a board-certified psychiatrist and geriatrician in Atlanta, Georgia, and is a locally and nationally renowned expert in the field of geriatric healthcare. He received his medical degree from St. Louis University School of Medicine, and he has treated various medical, psychiatric, and social problems of seniors living in assisted living communities for more than 25 years and has been in practice for more than 40 years. He has graciously volunteered to share his expertise with us today.
Now, getting back to the question was asked about what behavioral symptoms do you see with Alzheimer's disease? The main ones you can break down to are symptoms of anxiety and agitation, and then depression is closely intertwined with those. Whenever somebody is anxious or agitated, you want to oftentimes conceptualize it as depression. Anxiety and or agitation is a common symptom of depression. But let's just talk about agitation, because that's a biggie for you caregivers, and particularly in patients who are in the later stages of the illness. The treatment, very simply put, is it's a combination of environment. You're the environment, you're the staff, and the way that you intervene and interact with the patient. And then the medications can be used judiciously and cautiously in some cases when behavioral environmental changes don't work alone. But let me give you an example, though, of how important what I'll say is the environment, how important the environment is in controlling agitation. So before, when I was doing a lot of hospital work in my practice, I was lucky enough that the hospital I worked at had several geriatric units of different sizes, but there was one that was only 10 beds, and there was one that was 20 beds. And what I noticed was that at least 50% of the patients who had middle stage Alzheimer's or later that were having significant agitation wherever they were living prior to coming into the hospital, that when they came into the hospital and were put on the 10-bed unit with a high staff ratio, whether 3 or 4 staff patients per staff member, and it was very small, and it wasn't noisy, it wasn't overly stimulating, that at least 50% of the patients who had significant agitation prior to coming in had virtually no agitation whatsoever in the hospital. So that just tells you how important the environment is. And the Benton houses are good, and I like the size of the units. They're smaller than most of the other memory care units around, and there's not a lot of hallways and whatnot for the patients to get lost out of view from the staff members. So that's very, very important. But again, that environmental piece is critical. And what is that environmental piece? Again, we can break that down into 4 or 5 different things. One, as I said, the environment is the size of the unit. It's having the patients be kept in sight and visible so you can identify trains coming down the track if there's going to be some agitation, if somebody's starting to get a little overworked or confused or irritated about something, so you can intervene quickly. Those are very, very important factors. Just knowing what the patient's general routine and seeing what makes them happy and what doesn't. when you're interacting with somebody with Alzheimer's disease, the rules of thumb are never say no to them. And again, that literally, I mean that never say no, but I also mean it symbolically or metaphorically. You don't disagree with the patient. So if somebody's at the door pulling on the door saying, I got to get out, I got to go to work, you do not say you don't work anymore. And that's just one very simple example, which I'm sure you all know, but you can take that to the 10th degree on you got to get into the patient's mind and what they are thinking about, what's upsetting them, and you agree with them, you go with the flow. You say, for just a simple example, if someone's getting upset and they're at the door because thinking they have to go to work, and you can say, again, there's no one answer that's correct all the time, but you can say, well, okay, I know you got to get to work. But I want to go with you. So just give me 3 or 4 minutes. I got to go to the bathroom and put on my coat. And if you just can buy those 3 or 4 minutes, that might be all you need to redirect them. Now, it might very well come back again 30 seconds later, and that's a whole separate issue. But when you start thinking about the medications, it really boils down to, how effectively your behavioral interventions have been and how severe and how persistent are the symptoms. And when we're talking about agitation, again, persistence is an important criteria for me. There's another subset of agitation which I don't read a lot about, which to me is very, very important for you all and what you're doing in your work is what I call ADL agitation, activities of daily living. So that's an agitation that occurs solely or primarily when you're trying to bathe or change the patient, or you got your hands on the patient and you're touching them, and that's upsetting to the patient. So if somebody's calm, happy, and quiet throughout the day, and the agitation is mainly occurring when you're trying to get them to do something, whether it's bathe or change their clothes, or that's ADL agitation, what I call it. And why is that important? Because I just not have had a lot of success with medications and helping that type of agitation. And that's one of the ones that everybody wants medications for the most because it's the most difficult to deal with. But suffice it to say that medications aren't that helpful. The only thing that I'll recommend on occasion, if you've got a 250-pound, very strong man who's literally knocking out staff members, I'm being a little exaggerating here a bit, but somebody that's in danger of hurting themselves or others while they're agitated, occasionally / rarely, I'll say, okay, give a dose of Ativan 30 minutes before you're going in to do the shower. But that's not that often. But again, it's important that you realize that the medications don't help with that, in my experience, and a lot of others that I've asked. So you don't want to over medicate somebody trying to help with that type of behavior. With ADL agitation in showers, you can find with one staff member, it's just the approach that one staff member uses or the color of their eyes. There isn't necessarily logic to it. But the one thing you always want to do is whenever you're approaching somebody, the first thing you do is you want to assess them. You never want to approach them from behind, put your hand on them from behind. You want to approach them from the front, establish eye contact at arm's length if you have someone that's prone to agitation, and just look into their eyes and see if you can get them to smile a bit before you even start thinking about doing any types of ADL activities. And once you establish the eye contact, then a little touch goes a long way. If you start rubbing their hand a bit, or music goes a long way, or start dancing with them a bit before you, whatever works, music and dancing go a long way. But when you get into the middle of the late stages of Alzheimer's disease, talking doesn't help that much. So again, you're working mainly through eye contact and touch and TLC, tender love and care, and do whatever you can to make them comfortable, and don't even try to engage in any of these activities until you feel you've got them at least in a good spot, mentally and emotionally at that point in time. The takeaway point is you're not supposed to be unhappy just because you have Alzheimer's disease. So if someone's not smiling persistently, that might very well be depression. You can get anxiety and agitation with that. The anxiety and agitation with depression is more persistent, occurring more continuously throughout the day than with the ADL agitation, whereas the ADL agitation, the person that's screaming, yelling, kicking and screaming when you're giving them the bath or shower, that after the shower's over, you've got them in the dining area and they're kissing and hugging you and they're smiling and their mood's good. So that, again, that's not depression. I'll call that ADL, agitation. Other types of symptoms you can see: paranoia. If someone's agitated and they're paranoid and they think people are trying to hurt them or kill them or stealing things from them, sometimes the medications can be helpful for that. Uh, if the agitation is persistent and is occurring around the clock, there are medications that can help with that. Um, Hallucinations occur in Alzheimer's disease. Maybe around 20% of patients in the later stages of the illness. And as a rule, we don't necessarily treat hallucinations unless they're upsetting or scaring the patient or frightening them. So if they're seeing pictures of if they're seeing images of their grandchildren, no need to treat that. But again, if they're seeing someone attacking them with a butcher knife, you might want to treat that. Then I think those types of symptoms and the treatment approach goes for all the other types of dementia also, such as frontotemporal dementia, Lewy body's disease, and also Parkinson's dementia, along with vascular dementia. Learning to speak Alzheimer's disease, again, is another way of trying to emphasize what I said earlier, is that in the people that are having behavioral problems, more so in the middle, the later stages of the illness, you don't disagree with them. You don't say no. That's my riff on learning to speak Alzheimer's means. You're getting into their mental mindset, and you're not disagreeing with them.
Thank you for taking the time to watch this short video. I hope that you found it helpful. Remember, there's no perfection in the caregiving process, so always give yourself grace. You're doing the best you can during a very challenging time. By understanding a few key communication concepts and applying your learning, you'll become increasingly confident in your caregiving. Please, never forget to enlist the help of others if you are having trouble. This includes additional support from Benton House. If you'd like access to more Benton House Bites, our Confident Caregiving Workbook, or other caregiving at home tools, or if you'd like current pricing and availability for adult daycare or residency at one of our communities, please visit our website and contact your community of choice. We are here to serve you. Until then, be blessed in your caregiving journey, and love from your friend, Brandy Benton House, and the entire Benton House family.